All right. So my name is Mike Ivan. I'm also a third-year resident at McKay. So what I did for my project was kind of a continuation of my quality improvement project that I did over the 2 years at Midtown. Or the 2 years in residency. So mine is preventing missed opportunities for desired sterilization during cesarean sections. So first, a little bit about me. Hometown, I grew up in Pleasant Grove, Utah. I did my undergrad in exercise science at BYU. Medical school out in Kansas City. And then I'm going to practice at Sevier Valley Hospital, so with Intermountain in Richfield. So doing full spectrum family medicine. So inpatient, outpatient, emergency medicine, and obstetrics with C-sections. So first, just a little bit of background. Looks like we have a lot of former residents and stuff here, so probably pretty familiar with our C-section list. But McKay, for many years, has provided primary C-section training for rural docs. So to get on the list, kind of a very brief overview, you choose a mentor, which is usually one of the community OBGYNs. Once you do that, you work on assisting with that mentor, working through that process, and then after that first year, you kind of perform an oral boards with that mentor, and they will certify you to at least start doing primary C-sections. So my mentor was Dr. Lammy, who's with Ogden Clinic here, who's an awesome mentor, really helped. But we have a lot of support from the community docs. All of our C-sections are performed with the Ogden Clinic Laborist Group now, so that's new, probably since some of former residents have been there. But the Ogden Clinic Laborist Group provides 24/7 coverage at McKay, so we schedule with all of our C-sections are performed with them. Whoops. So just a brief overview of the numbers we're talking about. So in the time period, I forgot to put the time dates here, but this is from July of 2021 until April of 2023, so about 21 months. There was a total of 230 primary C-sections performed by residents. As far as sterilizations, we had 43 bilateral salpingectomies, one hysterectomy, which is a C-hist for Macrita, and then the total missed opportunities that we had during this collection was 2. So this is a very rare event, but I'll kind of talk this next slide of why this matters. So I got on the list July of 2021 and went in to do my first primary C-section. I was consenting her for C-section and said, well, are we going to do the tubal ligation or take my tubes out as well? And I went back. So this is a patient that residents have been seeing for months, and I was just meeting her that day. I went in and looked through all the records. We had no records of her, there was no consent form. There was no discussion about sterilization prior to that. And so that's when I kind of realized, oh, this is an issue. So as most probably know, through Medicaid, you have to have a signed consent form at least 30 days prior to sterilization and not more than 180 days before that takes place. So they're very strict. If you look at, there's a lot of kind of ethical considerations. Most would say that not having documentation at least 72 hours prior to sterilization is probably not a great idea. There's really this is Medicaid's hard requirement, which kind of stems from, back in the day when ladies used to get sterilized kind of against their will. Not necessarily against their will, sometimes it was the case. So that's kind of where this blossomed out of, and now it can create a barrier. We're not going to go into that now. But especially for our patient population, 70% of our patients at Midtown are uninsured. A lot end up with emergency Medicaid or some with traditional Medicaid as well. So these are a lot of patients that would not be able to get a sterilization procedure afterwards, with it, needing to be a surgery and everything else. So first, kind of as we go through the quality improvement process, and I'll kind of walk you through what we did, you'll see kind of this is the 4 basic steps of a quality improvement project, which I think was daunting to me at first, but then I saw, and hopefully will continue to do throughout my practice. So first, you're going to plan and a strategy. So create a team, establish goals, identify interventions. So on my team, I had one of the laborists, the residents at the time doing C-section, which during the first year, we had 5 of us doing primary C-sections. This second year, we've had 2 of us doing them. Added a laborist, Norma at Midtown Clinic, who's the prenatal the prenatal lead, yes, coordinator, there we go, as well as one of the labor and delivery nurses. So develop and test the strategy, and we'll kind of walk you through this later. Select the changes you want to make, identify barriers. Then we're going to monitor, implement those changes, and then monitor. A lot of times with projects we think of, oh, we need to change that, let's do it, and then we make a change and don't monitor it, so we don't really know if it gets better or worse. And then reassess and respond. And this is really just a cycle that can keep happening. So first, planned and strategized. So obviously, as we talked about, Norma, one of the laborists, L&D nurses, residents that were on, we identified our goal. And so we thought, kind of with team members, like what can we do that will make this possible? The logistics of prenatal clinic with multiple different residents seeing the patient throughout their prenatal care made it difficult. I think there's a lot of, especially if you don't feel super comfortable with sterilization consents or not knowing the process, it's easier to say, oh, well, the next resident that sees her will get it done. And that kind of happens until it never gets done, and she's not able to get that done. So our goal was to increase the number of successful tubal self-injectomy sterilizations performed prior to a missed event by at least 25%. Our selected intervention was to essentially add a step to the cheat sheet in prenatal clinic. So we have a cheat sheet that kind of at which weeks what needs to be done. And so we just added to that. Because we feel like when you're kind of overwhelmed in clinic, that's what you go to. You look at the cheat sheet, okay, what do I absolutely need to get done this time? And so we added this step. So this is just the little section that was added to the cheat sheet. So between weeks 30 and 32, this week was identified with Norma. So the MA as the prenatal lead, because we talked about they have so many things they have to do each clinic, she felt that, hey, this is a time we could help with sterilization consents and that we don't have a ton to do. So that would be an easy time for the MAs to help out with that. And so essentially it's just sending a telephone encounter to either the patient's primary OB or to the resident in charge, which this year was myself, to get that C-section done, as well as discussing sterilization. So now we had a time period for that to be discussed, where before it was kind of just vague, sometime prior to delivery, at least a month, and not everyone was familiar with those requirements. So added that on the list and discussed that at a resident noon conference. So during the monitoring period, so pre-intervention, we monitored, so from that first missed event we had when I started in July 2021 until the next missed event. So prior to our intervention, there was 10 successful sterilizations prior to another missed event. One of the patients who desired to have that done but also did not have any documentation prior to showing up to labor and delivery to have her C-section. So that was another one that couldn't be done. After that is when we did our intervention, which was adding that step and doing the resident noon conference. So post-intervention, after our first intervention, we had 18 successful sterilizations and no missed events up to that point. So now we're at the kind of reassess and respond. So, we'd increased from 10 to 18, so an 80% increase on the number of successful sterilizations prior to a missed event. We reevaluated, see what worked and what didn't. Overall, felt like things had worked. We'd at least made a change. People were more familiar with it. We did have, in that time period, one of the labor and delivery nurses came up to me and let me know there was a patient who came in, I don't know if it was a PPROM or something, but she needed to get her C-section done, and so we were filling out the sterilization for emergency. There is a kind of an exclusion on the Medicaid form where if it's going to be emergency surgery, you basically document why you could not perform, discuss sterilization prior to that 72 hours. And so you can fill that out. The nurse had asked one of the residents to do that, and they felt very uncomfortable consenting for sterilization. And so that kind of stemmed our next intervention we decided to do. As we were talking about barriers on creating that, it's like even though we have that they know they're supposed to talk about sterilization at that 30 to 32-week visit, if you don't feel comfortable doing so or competent in knowing what you should talk about, that's going to prevent people from getting it done. So as we discussed, we felt that the easiest way would just to do a quick teaching. Really, sterilization consent is fairly easy if you've done it or are familiar with it. The biggest thing to note is that the patient understands that this is permanent, non-reversible, And that is really, if you can get that across, that's essentially the main point of consent for sterilization. So plan to present, and then we surveyed the residents prior to our my teaching at a noon conference and after. So prior, as I would not have expected that half the residents did not feel comfortable or competent consenting for sterilization, which definitely made me realize that it was a good intervention to do. And then afterwards, we had about 50% did feel comfortable or competent consenting. We still had about 17% that didn't, and then at least 33% that felt somewhat comfortable or competent doing that. So we've monitored since that time. So before, we had any interventions, we had those 10 prior to the missed. This, we keep watching. We hadn't had a missed event yet prior to our second intervention, but also had, 34 successful sterilizations since that time. That's where we are at least as of April. So a kind of recap of monitoring the entire process over the 21 months is, since we started our first intervention, we have not had any missed sterilization events. Or, so 18 successful after that first intervention, and then an additional 16 successful prior to any missed, that second. So a total of 34 successful sterilizations before a missed event. Granted, this is a rare thing to happen, but felt that it was, a significant enough event that we should definitely prevent this with our patient population. So since that time, we have kind of reassessed and responded, talked with kind of the team members as well. So this is specifically for scheduled C-sections. There's also, we've had, as some patients do, are not anticipating a C-section and end up going to C-section from vaginal deliveries, and they desire sterilization, but a lot of times it's not really mentioned to talk about sterilization with our patients that aren't planning on C-section. So that is kind of the future of this project that I think will our patients could be benefited by. So have that discussion with everyone just in case they do end up going to C-section. We can get that done if they want it. So yeah, kind of take home points of this, especially for me, quality improvement's doable. Starting with baby steps, I kind of had some grand plans and ideas on how to change this at first, and realized after talking with the team members that most of my ideas probably wouldn't have worked out well. So having a good team and getting them involved and deciding what small steps you can do and monitor. Sometimes we have a desire to make huge changes and then monitor, and we have so many changes we can't really track what we did and what worked, what didn't, etc. And then just find a problem you care about, or at least one that bugs you enough to make you care. So that's with me. I saw this first and I was like, oh, this is something I don't want to happen. So to tell that lady that, she said, hey, I've wanted to get this done since, we started our prenatal care and we just don't have the proper documentation to get it done, was enough that I said, this shouldn't happen again. And so thankfully, at least the changes we've made so far have made a difference, and hopefully we'll continue to do so. Okay, thank you.